Assalamu alaikum. Good morning, good afternoon, and good evening. I hope everybody is doing great. Tonight we are going to have two lectures and we have to finish pneumonia. So the first one is going to be, uh, we are going to talk about, let me share my screen first. We are going to talk about, not this one, pneumonia and HIV patient, pneumocystitis, Girovasi pneumonia. Pneumonia and HIV or any immunocompromised patient. And then when we are done with this, then we will focus on doing some cases from pediatric pneumonia. But before doing that, we will definitely have a short lecture. Sohail Jones, Dr. Seb Sanaha, you both are the co-hosts. Please keep an eye on the other IMGs. If you see them trying to join, please let them in. Okay. Thank you very much. All right. So, what is pneumonia Girovasi, pneumocystitis Girovasi pneumonia? So, it is pneumocystitis Girovasi pneumonia, formerly called pneumonia or pneumocystitis carinii pneumonia or PCP. That was the former or previous name or old name. Now it is called PJP instead of PCP. Is an opportunistic pneumonia caused by unicellular fungi. It is strongly associated with impaired cellular immunity, especially in HIV and other immunocompromised states. So if they want to test you on this one, they usually give you a scenario about somebody who has, let's say, cough, fever, dyspnea, all signs and symptoms of pneumonitis, but the patient has HIV, or the patient has some sort of, for example, immunocompromised condition, or the patient had transplantation and the patient is currently taking immunosuppressant, and then you need to you have to know that, oh, I'm dealing with the PJP. So usually they give you a past history of these conditions: HIV, AIDS, immunocompromised condition, transplantation, long time steroid use. That's another thing to pay attention, and immunosuppressant. Okay. Transmission and pathophysiology. Infection and host response. Pneumocystitis Girovasi is transmitted via respiratory exposure, with infection often arising from the latent reactivation or reinfection in immunocompromised hosts, particularly those with a suppressed cellular immunity, which we did talk about it, right? So who is at risk? Again, as I mentioned before, HIV will be number one. And non-HIV is usually those who are immunocompromised. As I mentioned, organ transplantation, hematologic malignancy, or those receiving prolonged high-dose steroid. Or sometimes they only may mention that they have some chronic conditions, but they have been using immunosuppressant medication for a long time. So HIV-related individual with a CD4 count less than 200 without prophylaxis face a very high lifetime risk of developing PJP, especially if HIV remains undiagnosed or untreated. So remember that if you have an HIV patient, even if your patient with HIV does not have pneumonia, but the CD4 is less than 200, it means there's a high probability of this patient to develop the PJP. It means this is a cutoff. If it is less than 200, you have to start trimethoprim, sulfamethoxazole as a prophylaxis. Okay? So what does it mean? It means if you have an HIV who has no pneumonia, but the CD4 is less than 200, this patient is candidate for prophylaxis treatment or therapy. And what is the best medication for treatment and prophylaxis? Trimethoprim, sulfamethoxazole in both cases. Let's say you have an HIV patient, and the HIV patient, regardless of the CD4, the patient has PGP. So the treatment is the trimethoprim sulfamethoxazole. Now you have a patient, your patient is HIV, but the patient does not have pneumonitis or pneumocystitis or PGP. Now, do you have to still start the trimethoprim sulfamethoxazole because the patient does not have the pneumonia yet? Yes. Why? Because we want to prevent pneumonia from happening. Obviously, the dosage is different, the timing is different, but you have to start it as a prophylactic or prophylaxis if the CD4 is less than 200. Remember this, okay? Very important, and they love to test you on CD4 count and its relation to the PGP in HIV patient. Now, for the non-HIV patient who is immunocompromised, again, if the patient develops the PGP, the first best choice is trimethoprim sulfamethoxazole. Okay? Unless the patient has some sort of allergies to sulfa medication. In that case, you change the sulfa with dapsone. Okay? Trimethoprim will stay the same, but you remove the sulfa. Clinical presentation of the PGP, understanding symptoms and progression. Symptoms of pneumocystitis jirovecii pneumonia often develop subacutely and progressively, including fever, non-productive cough, and increasing dyspnea. Hypoxemia may be present, often disproportionate to the physical examination. Imaging findings, X-ray, and CT scan. So these are the things that, these are the clues actually, are the most, or the best characteristic finding of X-ray finding of the PGP. These will be part of your scenario as a clue. Let's say you have a patient who's acutely developed cough, fever, dyspnea, and now when you do the CT scan, the chest X-ray, you find bilateral interstitial infiltration, while CT reveals diffuse ground glass opacity. Okay, these are the keywords. Usually, the ground glass opacity is characteristic for PGP. Not only for this one, it is also characteristic finding for viral and inflammation of lung. Okay, ground glass opacity. Bilateral interstitial infiltration and diffuse ground glass opacity. Crucial for diagnosis of pneumocystitis jirovecii pneumonia and in immunocompromised patient. Again, they will give you a scenario about someone who has HIV, or he doesn't have HIV, but he had a lung transplantation or kidney transplantation or some sort of organ transplantation, and the patient has been taking immunosuppressant, or the patient had a chronic condition and he was taking long-term steroid. So in all these cases, when you do the CT scan, like one of them is in that scenario, so the chest X-ray, the chest X-ray shows bilateral infiltration, and the CT scan finding, the chest X-ray is bilateral infiltration, but the CT scan is ground glass opacity. So these are the clues that I know the patient has pneumonia, my patient is immunocompromised, so the patient has PGP. So the key investigation, ABG, measure oxygen, very important, measure oxygenation level showing reduced PaO2 and increase AA gradient. Why it is very important? That might be a part of a question if you're doing a NACOSCI as a post encounter. What is the benefit or the importance of or the significance of doing ABG in a patient who is suspected to PJP or who has PGP? So if it is reduced, let's say if the PaO2 or the A gradient is abnormal, like AA gradient is more than 35 and the PaO2 is less than 70, it helps me to decide the proper treatment regimen. For example, if you're treating the patient with the medication, let's say trimethoprim sulfamethoxazole, and if this is less than, or the PaO2 is less than 70, but the AA gradient is more than 35, I can add prednisolone. So that's why it's very important, because it helps me to approach, or it helps me to map out a proper treatment regimen for my patient. So in which condition you add a steroid? When these two are abnormal. Remember the numbers, when the PaO2 is less than 70, but the AA gradient is more than 35, then you can add prednisone. So serum lactate dehydrogenases, or LDH, what is the importance or significance of this one? This is also part of my investigation, but why do we do it? Is it a definitive diagnostic? Is it confirmatory investigation? No, it is just supportive marker for the PJP, but it is not diagnostic. Is it part of the investigation? Yes. If my all investigation, including all the history taking and physical findings, are pointing toward the PGP, this will support it. But it's not a confirmatory or definitive diagnostic investigation. Remember that, supportive marker. It always happens when there is a necrosis or lung injury. So it cannot be very specific for PGP. Microbiological confirmation, the PCR testing from induced sputum or bronchoalveolar lavage. Remember this one, very important. That's why I made it all red. So the PCR from induced sputum or the bronchoalveolar lavage is preferred for definitive diagnosis of pneumocystis jirovecii pneumonia. So now, if you have a PGP, what is the definitive diagnosis? PCR. What is the supportive diagnosis? That will be the LDH. Are you going to do the ABG? Yes. Why? Because it helps me to decide if I can only continue with antibiotic, or do I have to add a steroid. If the PaO2 is less than 70, but the AA gradient is more than 35, then I can safely add prednisolone. Treatment overview. Obviously, the first best initial treatment, always it's going to be supportive. Okay, essential supportive care, including oxygen therapy. And why do we do oxygen therapy? To keep the oxygen level above 90. And probably that might be also one of the questions, which usually hardly happens in the licensing exam if they ask you about the percentage, but that could be one of those exemptions. Exceptions, that how much do you have to keep the oxygen? Above 90. So antimicrobial, the first line treatment is trimethoprim sulfamethoxazole, available in both oral and IV formulation, effectively okay, so I did mention this. This is not only the first line of treatment, it is also the first best choice as a prophylaxis. So what are the alternative options? Let's say if the patient is allergic to sulfa medication. For patient intolerant to trimethoprim sulfamethoxazole, alternative regimen will be include dapsone plus trimethoprim or clindamycin plus primequine, which ensures effective management of the pneumonia. So remember this part as well. Adjunctive steroid, I think I did mention this, so I'm not gonna. So when are you gonna add a steroid? When the PaO2 is less than 70, and I think I should add the AA gradient and against severe asthma. Okay, so I did mention it over there, so just remember it. Because the PaO2 less than 70 indicates severe hypoxemia. Okay, treatment benefits. The addition of a steroid improves outcome in patients with severe hypoxemia, effectively reducing inflammation in the lungs and enhancing oxygenation during treatment of PJP. Prevention strategies. So trimethoprim, sulfamethoxazole, as I mentioned before, it is the best treatment and prophylaxis choice. And when do we start it? When the CD4 falls less than 200. Okay. Non-HIV candidates, like non-HIV immunocompromised patients, should also receive prophylaxis based on their level of immunosuppression and associated risk factor. Reduced incident prophylaxis plays a critical role in minimizing the incident. So basically, it is preventing it. Now, for prevention strategy, I added an extra note: trimethoprim prophylaxis. So we have the common prophylaxis schedule is one double strength. When we say double strength, so this is 160 over 800. It means 160 of trimethoprim and 800 milligram of sulfa. So our single tablet daily or single strength, which is 800 over 400 once daily. Or they all should have or. I can change it so it has or, okay? So either this one or this one or this one. One double strength tablet 3 times weekly, for example, Monday, Wednesday, and Friday. Okay? So these are the way how you do the prophylaxis. Now, when to stop and when to restart the prophylaxis. So stop. When do we stop it? When it goes beyond the threshold, which is the 200. If it is less than 200, we have to start the prophylaxis. Once it is above 200, we have to stop the trimethoprim sulfamethoxazole. For at least 3 months on effective ART. We don't have to do it right away as soon as it goes up. We need to keep it at least for 3 months. When to stop and when to start, okay? Now we mentioned about when to stop it, right? When for 3 months the patient stays above 200, I will stop my sulfamethoxazole, trimethoprim sulfamethoxazole. But when do I start it? As soon as it gets less than 200. So if the CD4 falls less than 100, or if it falls, if it is 100 to 200 with the loss of virologic control, sustained detectable viral load, not just a single brief blip. But as soon as it drops less than 200, I have to restart it. So take home message. The PJP is an opportunistic fungal pneumonia classically seen or called as PCP with a CD4 less than 200 or other major immunocompression. Expect dry cough, so it doesn't have a sputum. It has cough, but it's dry. Progressive dyspnea, hypoxemia, bilateral interstitial infiltration on chest X-ray. But remember, in CT scan, it will be ground glass appearance. Diagnosed with induced sputum, we do the PCR. Treat with a trimethoprim sulfamethoxazole and add a straight one. Hypoxia is severe. When we say hypoxia is severe, it means when the PaO2 is less than 70 and the AA gradient is more than 35. So prevent with a trimethoprim sulfamethoxazole. And if you have any questions, I would be at your service.